So, we manufacture a lot of different devices depending on what the patient's needs are. And one of the things that we do quite frequently is we create new types of designs and devices. One of the things that we've come up with is this Duraflex inner boot. It's a very soft and flexible, very malleable material. And you would use this for lots of different reasons, lots of different applications. One of them might be a child or an adult that has a lot of spasticity or a lot of excessive motions in their foot or ankle joint. And this really holds the foot and ankle in a position where it needs to be so that they don't get blisters and sores, and you can really control spasticity and things like that, or reduce spasticity with this type of total contact type of device. So there are instances where this is just not enough and they can pull out of the device. This obviously goes into an AFO, but there's times when this just isn't enough. So we've come up with what I call a triple threat, which when parents hear that, they really kind of like, what are we doing here? But this type of device, this little anterior shell or front shell, goes over the inner boot. It's very thin and flexible plastic itself, but when you have this first material and then the second piece going over it, and you can lock that into, it kind of clicks into the actual AFO. If you've had an adult or a child that's just inherently pulling out of a device because of spasticity, this really is able to lock them in and give them that total contact feature that they need. The other nice thing about this is if you have a place on the foot or ankle that is just very compromised, if they have an area that is known for breakdown or blisters or pressure, things like that, you can actually do cutouts in the more rigid material and have relief of the inner boot and that anterior shell. So it's a great device, it's a great option. You can incorporate soft padding into the inner boot or that anterior shell to give a great total contact feature to it. This would be used, this is like I said, an AFO or an ankle foot orthosis, and it would be really used for a situation where they're either on their toes, toe walkers, or they don't have the strength in their lower extremities that they need, and they need support to the foot and ankle, which can inherently have an effect on the knee if there's weakness in the knee also. So this is an AFO. All right. This is another type of AFO. There's lots of different types of AFOs. This is called a floor reaction AFO. We've named it a turbo. And the reason that we would use this, it's this floor reaction type of design where this is actually the front, just below the knee. And the purpose of this is really to give more control to the knee without crossing the knee joint. Just because this inherent design with this anterior shell or front shell, we can actually, when the foot hits the ground, it'll actually push the knee back to give you some more stability. Well, the problem with this device has always been is in order to give the rigidity to the ankle, you had to use really super thick plastic to give that stability or rigidity to the plastic. But what we've done is we can use very, very thin plastic with some padding, and then we can take an extra strut of material. This is actually just an extra 1/8 inch strut of material and design it so it just goes in the places where you need for that extra rigidity and keep that very, very stable, very, very light, but give the stability to the knee and the foot and ankle that you might need. The other nice feature about this is it's what we call a step-through design, where their foot would actually go through like so and then back in to make it very easy to don and doff or put on and take off of the AFO. Very easy for children, very easy for parents to take care of. Not a lot of straps, and it's a very rigid device. You can also incorporate the inner boot into this if there's a lot of motion that you're trying to reduce in the foot and ankle. So that's a floor reaction AFO, what we call a turbo AFO. This is a KAFO, or a knee ankle foot orthosis. There's lots of neat things about this particular KAFO. A lot of times when people think of a knee ankle foot orthosis, they think of the old Forrest Gump type of device where, it's a metal leather type of device with all these fancy straps and things like that. But they've come a long way since the 1940s and 50s when those devices were really being utilized with polio. This particular device is still considered a knee ankle foot orthosis, and we still make those old Forrest Gump type of KFOs if the patient requests that, and if that's what they've had in the past, and if it works the best for them. But this is a thermoplastic, so it's a plastic shell, thigh shell, plastic AFO shell. It still incorporates the same inner boot if it's needed. This particular device is fabricated for a child that has joint contracture issues. So they're able to put on the inner boot, and then if they're in a particular position where their knee might not get to full extension, and this is used on adults also, is it's set, let's say, in this flexed position, and let's say they can only get extended to that position. If we want, it'll lock, and if they want to try to stretch out a little bit more, it'll lock. It locks in about 8-degree increments. Hopefully, the goal would be they'd get to full extension, and they could eventually be in an extended foot and ankle or foot and knee position for weight bearing. This child actually wears 2 of these, and he's able to stand with his knee slightly flexed and we have a buildup on the heel so he can get his weight line appropriate. The other really neat feature about this is a lot of kids and adults don't necessarily want to wear the knee ankle foot orthosis full time. So let's say they're not ambulating and they're in their wheelchair and they still need some stability of their foot and ankle, maybe if they're just doing some transferring and they just need the AFO. Instead of making a complete separate device, we've come up with this removable system where they can wear just the AFO, and then if they want to go back into the KFO, all they need to do is click this in, and then there's a little pin release system that they click in, and now it's one device. It's a very stable, very easy to use for the particular patient. One of the other neat things that we're always accommodating is we think about how can this person or the patient put on this device. So for this particular patient, he has hand dexterity issues. So we're able to just combine 2 straps into one strap and make finger loop systems so he can actually just put a finger in and remove the strap. So just always very accommodating and thinking about all these different options for patients, whether it be a patient that just had a stroke and we need to think about those types of things for donning and doffing, or a child or an adult that's been wearing a device for a long period of time, making it as easy for them to use. A device can be a great device, but if it takes 2 hours to put on, they're not going to use it. This is another version of a KAFO, and this is particularly used for contracture management, both in adults and kids. This particular one is for a child, just for ease of show. But this is called an UltraFlex knee joint, and this is a great joint because you can use it really in any joint that has a contracture. So this particular one is at the knee. You can use them at the ankle. You can actually use them at the hip if there's an issue with the adductors or the legs that are being too tight being brought in and they're scissoring, or if a patient has had a post-op hip replacement, they need something to give them as much abduction or a hip spreading as possible to make it to make the surgery really do what it was planned to do. So you can actually have 2 of these devices put together with a hip joint between to spread the legs if that's what's needed. But this particular one is for hamstring or gastroc or soleus tightness. So let's say that the patient is in this type of position, they're flexed and contracted in this type of position. One of the things that, you know, in the previous, the step block where it goes click, 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 you're really stuck on those positions, and it's not a continuous stretch because you just get to that one position, then you'd have to push the leg down again to get to the next click. This particular joint gives a constant stretch. So this joint is able to range from 0 to 7 as far as the strength of the torsion of the joint. I'm just going to give you an example. This is just set on 2. So if there's a real tightness in those hamstrings and you're trying to stretch those out at night or during day, it will continually stretch the leg out to give that stretch that they need to the hamstrings or the affected joint. This particular device is fully lined with soft padding. It's really just it needs to be very, very comfortable for them to sleep with, or if they're using it full time during the day to get that contracture out. With physical therapy, they're working on contracture control, but when they see a physical therapist, it might be for 1 day a week or 3 days a week and for an hour at a time. If you don't have that carryover at home or in the clinic, then it might be lost. What they've gained might be lost. So this is really an augmentation and assistance to what they're using in therapy. So this is another version of a KAFO, and it is this. What I really want to show in this device is the actual ankle joint, not to focus on the rest of the actual device. This is a fairly new joint that we're utilizing. It's called the USG ankle joint, and it is a fantastic addition to our practice because we can do so many things with this ankle joint that we haven't been able to do before. It has really 4 chambers in this ankle joint, and a very small joint at that. There's urethane rods in the front and the back which give resistance. So you can, if somebody just has drop foot, you can tighten this posterior rod or this back chamber and it will lift the foot back up. If you need resistance to the knee from collapsing or there's weakness in the calf muscles, then you can tighten up this front chamber to give a substitutive push-off, if you will. Now, if you needed to have a stop, for example, if there's just complete weakness in the foot and ankle and you need to have a rigid stop to give the support to the foot and ankle, then you would tighten one of these 2 middle chambers here to give that stability that you would need. One of the things that we're doing that is a little bit different is if we need to have specific control to the foot or ankle where it's collapsing either in or out, we're actually putting the joint mounting on the outside and having a high trim line wherever we're needing more support. It's a very new creation that we've come up with, and we'll be talking to others in the field so they can hopefully benefit from this type of creation. So this device is called a CROW, C-R-O-W, Charcot Restraining Orthotic Walker. And this is used mainly for adults who might have a compromised foot or ankle. Lots of different reasons that you could either deal with an ulcer on the bottom of the foot or the plantar surface, or you could have what we call a Charcot foot, where the joints and the bones in the foot and ankle are just kind of not how they should be. And we need to really immobilize that foot and ankle and not going into a cast. Obviously, when there's a cast put on, you can't remove it unless it's taken off by a physician, and you can't really look at the foot. And one of the things that's very important with a compromised foot in a patient that might have diabetes is they need to visually inspect the foot on a regular basis. So this device is very modifiable for each particular patient. It's a custom device where we take a cast of the patient's foot and ankle, and depending on the position that we need to have their foot and ankle, that's where we place them. Then we have what's known as a rocker sole, where it has a little bit of a roll to it, so you can the motion that's taking place is not in the compromised foot or ankle. It's actually transferred through the sole of the device. So this is really the basics of it, this posterior shell with the sole. But then the other component to it is this removable foot orthosis that is placed into the plantar surface or the insole of the CROW. And the nice thing about this is we can take this out. If they have an ulcer in, let's say, the first metatarsal head, we can remove material in this spot to give inherent relief to the actual foot. So this device, this little insert, and there's extras of these that the patient gets, but this just goes inside of the device. Foot goes in it. This anterior shell then clicks over the device like so. And then the Velcro straps get fastened, and basically they have a rigid device to stabilize their foot and ankle and hopefully heal that foot so they can get into regular shoes when their foot and ankle has healed. So one of the other orthotic management things that we deal with on a daily basis is dealing with the spine. And one of the things that we see a lot with kids is scoliosis. This is really the gold standard, and it's been since the 1970s. Before this, the predecessor was the Milwaukee brace, which you had a neck ring that came up and was very difficult for kids to wear. And then in about 1979, this device came out, incorporating a thermoplastic type of material, and it was called a Boston brace. And we've taken it to really the next level, where we take an actual cast of the patient and we fabricate this device ourselves. This particular curve, what we'd be dealing with would be what we call a right thoracic and a left lumbar curve. So you can look on the inside, there's a pad for the right thoracic curve, and there's a pressure and a pad for the left lumbar curve. This is obviously the top front and then the top back. And the goal with scoliosis management is really to resist the curve from progressing to where we initially saw it. So if a curve started at 30 degrees and the child was 13 years old, when they were done growing, when they've reached skeletal maturity, 15, 16 years old, we would hope that that curve, when they're out of the orthosis, would be at 30 degrees. If it is, then we've met our goal. If we get more correction when they're done wearing the orthosis, then that's great. But really resisting the curve from progressing is really our ultimate goal. Now when they're in the device, the goal is to get 50% correction. So if we've got a 30-degree right thoracic curve, we'd like to get that down to 15 degrees. And that's the ultimate goal. If it doesn't, then there's either an issue with the device or the curve is just so rigid and there's too many rotary components that we just can't get that out of the device. But that's the ultimate goal. This is a Boston brace. A new addition to scoliosis management is really nighttime management. This has probably been out for 10, 15 years. The Charleston bending brace was really the first one that was used for that. This is called a Providence device, and it's a very elaborate casting or measurement board that we have to put the patient on. And not everybody that has scoliosis is a candidate for this. It has to be a specific curve, typically a thoracolumbar curve where it's not a real high curve up in the spine, but in really the middle of the spine. Now there are times when you would use this type of orthosis for also a right thoracic or a left lumbar curve if there's issues with compliance or they've reached a point where they're close to being done with growth and we just need something to hold them until they're done growing. But really the goal with this orthosis is to get maximum correction in the orthosis. So if the curve once again was say 30 degrees, we would like to get this to 0 in the orthosis. You're going to have most likely the same outcome when they're done growing, where you might still be at 30 degrees when they're done, but really inside the orthosis is to get as much correction as possible. So you might ask, why would you not use this device on everybody? Well, you're only using this at nighttime. This is specifically a nighttime orthosis. And some people would use the Boston type of brace for daytime and use this for nighttime so you can get the full effect of weight bearing and having gravity working on your spine and getting the Boston brace results, but then use this at nighttime for maximum correction. This is the front, or the back top, or the posterior proximal, and then the inferior, the bottom of the brace of the back. And then this is the front. So you can see it's a less intrusive type of device. Some people think it's more comfortable even though you're getting really a real side bending effect when you're wearing this at night. But it's a very beneficial device, especially if there's a compliance issue. In addition to the custom spinal braces that we've talked about, we also provide post-op care for hospitals. So if a patient has had a trauma and they're in the hospital and they need trunk stabilization, we may be called to go into the hospital to either design a custom fabricated device or what we would call a custom fit device, where we could put together different modules and create a device for that particular patient. It could just be as simple as a corset or a full TLSO or thoracolumbar sacral orthosis. We probably have hundreds of different types of devices that we can use for patients. But once again, if it's a custom device that's needed, we can do that either by measurements or casting. And we have the ability to do that in a one-day turnaround if necessary. But once again, if it's just a simple corset, we have those for the same day, or any of the post-op or trauma type of thoracic devices that we do have in stock that we can fit the same day, or if a custom device is needed, we can do that the next day. So we would be able to patient can either come to the office for these types of devices, or if we are needed, and which is most often the case, the hospital would call us directly and we would go to the hospital to see the patient either in ICU or in the room or with therapy. And a lot of times these patients need these types of devices to get up, to have before they're even able to get up, to stand, and they need it before therapy. So we're very understanding of that, and if they're needing it at 11 o'clock, obviously we'll be there beforehand so that they can start their therapy to prevent longer hospital stays than are necessary.